Hello, everyone. My name is Simran Chaudhary, and I welcome you all on behalf of Voice of Healthcare to this special panel discussion, part of Voice of Healthcare's ongoing arthritis awareness campaign themed Arthritis in India Gaps, Opportunities, and Path Forward. While World Arthritis Day serves a global reminder of the growing burden of arthritis, at Voice of Healthcare, we believe that awareness shouldn't just be peak on a single day. It must continue year round as part of an ongoing effort to inform, engage, and empower both healthcare professionals and the public. Through this campaign, our goal is to spark meaningful conversation around early diagnosis, access to care, and the latest advancements transforming the way arthritis is managed in India. As we know that arthritis affects millions across ages, backgrounds, and lifestyle, yet remains one of the most under-discussed chronic conditions. So the impact goes far beyond joints. It affects quality of life, productivity, and emotional well-being. And that is why today's discussion brings together some of India's most respected voices in rheumatology to unpack the current challenges, identify gaps, and explore opportunities that can pave the way for better outcomes and integrated care. Before delaying further, I would like to start to introduce my speakers for this amazing panel discussion. Dr. Indrajit Agrawal, Clinical Director, Rheumatology at Marengo Asia Hospitals, Gurugram. Welcome to our show, sir.
Thank you
for joining, sir. Dr. Sajal Ajmani, HOD in Rheumatology at Manipal Hospitals, Dwarka. Welcome to our show, sir.
Thank you.
Thank you so much for joining. Dr. Ashish Baweja, Consultant Rheumatology at Medanta, Gurugram. Welcome to our show, sir.
Thank you. Thank you.
Thank you so much for joining. Dr. Kaushik S. Bhojani, Director Rheumatology at Fortis, Mulund. So has just joined us. So moving ahead with our important discussion for today, I would like to start by Dr. Sajal Ajmani. So in your practice, what could be some earliest clinical or imaging cues that help identify inflammatory arthritis before joint damage sets in? And how can early detection protocols be improved in India?
Yes, thank you for that question. It's great to speak on this important topic today. So first thing would be to start with a good clinical history and examination. So asking the patient about multiple joint pains, things like early morning stiffness more than 30 minutes. And then in the examination, looking for subtle signs of inflammation, which would be a joint swelling and limitation of the motion of the joint. For example, in the wrist, extreme flexion and extension, pain at that motion might be an early sign of arthritis and inflammation. Then, as far as imaging is concerned, X-ray changes take a long time to develop. So now newer modalities are available like MRI and ultrasound. Ultrasound would be one which is most preferred now because it's easier to do. Many rheumatologists have ultrasounds in their own clinic, and it can pick up joint synovitis and inflammation in the joints and increase vascularity and things like effusion, which may be missed by a clinical exam. MRI is also good, but it's slightly more expensive, and some people, if you don't have a peripheral joint MRI machine, they do not like the claustrophobia of and ultrasound would be a good imaging modality, and many rheumatologists are now trained in doing musculoskeletal ultrasound. As far as picking up early disease would be to raise awareness between primary care physicians in the public about asking history and examining for these joints. Plus, now lab testing for these disorders is now becoming more and more available and affordable, which should improve the early pick of these diseases.
Thank you so much, sir, for that response and giving us and our audience, educating and awareing about this particular thing. My next question is Dr. Ashish. So, from your perspective, how can national programs such as NPCDC and NPHCE be leveraged to include arthritis screening and referral at the primary care level, so that it doesn't go to a later stage where the treatment is little difficult?
So, thank you for the opportunity. And this is actually something which bothers all of us as rheumatologists dealing with patients, that we are usually seeing patients at a later disease stage when the disease has already set in and done damage. So screening early is one of the most important factors about changing the course of the disease and how the disease is managed. So both the programs, the one which is for control of non-communicable diseases, that's the NPSCDS, can take care of one of the diseases, which is rheumatoid arthritis, and the other one can take care of the other most commonly presenting arthritis to our clinics, that is osteoarthritis. So as far as rheumatoid arthritis is concerned, we have a very vast disease burden. We have around 18 million cases in the world, around 5 to 6 million of them in our country. The main distinction which actually is there is to train people or healthcare workers at PHCs or CHCs is to differentiate between inflammatory and non-inflammatory nature of the disease. So pain will be there in all forms of arthritis, but swelling, as Dr. Sajal pointed out that along with the pain, there will be swelling, there will be increased temperature and morning stiffness, which goes more towards the nature of inflammatory joint disease, in which we can intervene, give drugs, and modify the course of the illness. And also there will be systemic features such as weight loss and decreased appetite. So questionnaires associated with these things can be incorporated in a national screening program for non-communicable disease to identify such patients. On the other hand, when we come to the other aspect of it, which is osteoarthritis, the other program, which is the National Program for Healthcare of Elderly, can deal with it. It already has a provision for joint pain. Tests such as time up and go tests are fairly simple tests, which can be used for screening and do a very good fall risk assessment in patients with osteoarthritis. They hardly take 12 to 15 seconds and can be incorporated easily to screen these patients. And then again, there has to be a referral link which has to be set up for patients from PHC to CHC to tertiary care centers, so as to manage these patients more comprehensively. Thank you.
Thank you so much, sir, for explaining us that. Moving on to my next question to Dr. Kaushik. So, first, I would like to welcome you to this session and thank you for being part of this.
Thank you very much. Thank you. Very kind of you.
Thank you so much, sir. My question to you is that functional disability due to delayed diagnosis is a major challenge. And how can this multidisciplinary management involving physiotherapy and occupational therapy help improve long-term outcomes?
Actually, the question itself is the answer, isn't it? So if you actually have to turn around and look at the fact that the joints are weak, they're inflamed. Dr. Ashish just told you that. Dr. Sajal just told you that. The joints are inflamed, the joints are weak. What is going to support those joints? It's going to be your muscles. You will have to. One of the other things is the fact that even if you go to old age related bone weakness, which is what we call osteoporosis, the first line of management is exercise, weight bearing exercise. So wherever you go, exercise becomes indispensable. However, you can't go around and tell the patient go to the gym, because their certain joints are inflamed, they're weak, they're swollen. And so there has to be a guided modality of exercise. There has to be a systematic kind of protocol on the basis of which the patient can restore the mobility in the joints without harming something else. And that's why what is physiotherapy per se? Physiotherapy is guided exercise using the principles of medicine, using the muscle structure, the structure of the body to see which muscle is important and which one is not. So it's indispensable. When you treat the patient adequately with arthritis, you might take away the pain and inflammation, but the weakness still remains. And if the patient has come to you much later, the joints are partly damaged, so there are already deformities. Now, under the circumstances, you want to restore the quality of life for the patient. How else are you going to do it without really supporting them with strong muscles? And trying to restore as much mobility amongst the ligaments of the joint. So physiotherapy and occupational therapy become indispensable.
Very rightly pointed out, sir, and thank you so much for explaining us this. Moving on to my next question to Dr. Indrajit. So, as someone who has built rheumatology department, what could be that essential systems or clinical pathways can hospital adapt to streamline early arthritis referrals and management?
Yeah. It is very important. First of all, let me first explain that what is early arthritis. So when we talk about early arthritis, it could be 1 month, 2 months, up to an year. And in the Western world, there is a definite reason why, or in our country too, that why it should be early arthritis referral, because there are so many good treatment available. And if you have an early intervention, early diagnosis, then you have the best possible result for the patient. Not only that, you also have to plan your budget, some expenses, how many patients are coming through the door and what will be the expenses incurred by the government or authorities. The third thing will be very important to sort of calculate that what could be the possible outcome by doing early arthritis referral in terms of your doctor management, like how many doctors you want to be in a given area. So I think probably what we used to do in setting up early arthritis clinic way back about 10 years ago, that we first increased the awareness among the doctors as well as the patient. Then once we raised the awareness, we gave them a kind of a tick box exercises to the general practitioner that, once you have, as Sajal had very eloquently described, the morning stiffness, pain, swelling, weight loss, fever, ESR, CRP, the pain lasting for more than a year, 1 month or so. And then, of course, the family history and so on. So then if you do the tick box by it could be a physiotherapist, it could be any healthcare worker, it could be a general practitioner. And then this patient will come to the attention of a specialist care unit. And then the specialist care will see that and then get the patient into the specialist care. So I think probably because we lack these kind of arrangements in our country, but the first and foremost thing will be to again raise the public awareness, raise the awareness among the doctors and among the medical care practitioners. Maybe like some people who are internist, orthopedic surgeon, maybe physiotherapist. If you skill them with the knowledge that what it is rheumatoid arthritis, and give them very simple formula to distinguish between rheumatoid arthritis and osteoarthritis or something else. So they'll be able to refer the patient to the direct place, like to see a rheumatologist, which is very important. Unfortunately, we still do not have many rheumatologists in many districts and subdivisions. And this is where the rheumatology care and promotion of rheumatology is needed. And I think probably all the different universities, different programs, they're now increasing the seats so that adequate number of the rheumatologists are there all throughout in India. And I can see in the last few years since I'm back in return to India, I see the number of rheumatologists has increased. Do require many more fold of rheumatologists in India. So I hope I'm clear. Thank you.
Very rightly said, and thank you so much for explaining this. As we are moving our focus to innovation and integrated care, my question is to Dr. Sajal. So, you have expertise in musculoskeletal ultrasound. So, how do point of care imaging and digital monitoring tools improve arthritis diagnosis and treatment planning?
Yeah, so I spoke a bit about ultrasound earlier. Let me divide the use of ultrasound into three subparts in rheumatology. One would be for early diagnosis, Second would be for monitoring the disease and maybe helping with planning the treatment. And third would be in giving interventions like joint injections. So ultrasound guided steroid injections in the joint. Early diagnosis, like I said earlier, sometimes it is unclear on clinical examination if the patient actually has synovitis or not. Many patients would come with a positive rheumatoid factor, maybe a borderline ESR CRP, and you're not sure if the patient has started having rheumatoid arthritis or not. In such a patient, joint doing a focused ultrasound of the joints in which there is some pain and checking for things like effusion, increased vascularity, and synovitis will help us in diagnosing early rheumatoid. Plus, it might show another reason for the pain. For example, it might show in the shoulder ultrasound a tear of a tendon or some rotator cuff tear. So it might also provide you an alternative reason for the pain and not necessarily an inflammatory arthritis causing the pain. So one is to pick up early. Second would be monitoring the disease. Patient is doing well, you want to see if you can decrease the dose of the medicines or not. So you might do a focused ultrasound of some joints and look at if there is no synovitis or increased vascularity, blood flow in those joints. If it is still showing a lot of vascularity, you might decide not to decrease the medicine for now. Then third, like I said, it has been shown in multiple studies that giving blind injection, ultrasound guided injections are when compared to giving blind injections. That is when giving in joint injection without the ultrasound guided injections reach the place where they're supposed to and have a better effect and lead to better treatment outcomes. However, again, at the end, I would say that doing an ultrasound should not decrease your time of talking to the patient. I would still keep talking to the patient, taking a history, asking them how they are doing, which activities they are able to do and not to do. That should remain. Because you're spending 5 minutes or 10 minutes doing an ultrasound should not take away those 5-10 minutes from actually talking with the patient.
Very rightly mentioned, sir, and I think that's how initial trust is also built, and it helps a long way to go. My next question is to Dr. Ashish. So, biologic and targeted therapies are changing the treatment paradigms. So, how do you balance innovation, affordability, and long term patient monitoring in the Indian context?
So very rightly pointed out in our Indian context, the main challenge still remains the expense of therapy when it comes to using biologics or the newer agents that we are available. We still want to stick to firstly giving out a trial or not trial per se, but we still want to use conventional therapy that are available since long as our backbone therapies. And because mostly patients, 60-70% of patients are bound to respond, specifically when we are talking about rheumatoid arthritis and not another form of arthritis. But then whenever we are switching to a biologic, when the patient is refractory or we have another form of disease like ankylosing spondylitis or something on the spondyloarthritis spectrum in which the conventional therapy is not going to do well, then also now over the past 10 years, we have been getting good number of biosimilars in our country. And most data has shown that the efficacy is almost similar to the original biologics which are available. And biosimilars now are available for most of the biologic original molecules in our country, which have drastically brought down the cost. But those still remain expensive when are to be taken on a prolonged basis. Because when we are counseling patients, we are not counseling them for treatment for a couple of months or 3 months. It is going to be there. We might reduce the frequency of the administration, but the drug is supposed to continue. So we have to take that into account, and that initial conversation with the patient has to be there. The other thing that has come up is the use of JAK inhibitors, the oral small molecules, which are equally efficacious as compared to some of the biologics in some trials. Although the safety profile is still not very clear, but usually when we are using them in patients of age less than 50 years, they're relatively quite safe. I usually used refrain in patients more than 65 in my practice, but the younger patients, which are actually the ones who are needing them more, do fairly well on these agents. As far as monitoring is concerned, also we in our setup, we have to formulate our own set of monitoring frequencies, or let's say intervals, because we cannot go by what is actually there. If possible, we should be monitoring according to the standards, but then what I usually do in my practice is a 6, 8, 12, 16 week follow-up whenever we are starting a newer therapy for a patient. Then again, I would again want to emphasize, we'll still want to switch to stick to conventional therapies as initial management in most patients with rheumatoid arthritis. Thank you.
Thank you, sir. Thank you for that explaining us to us and to our audience. My next question is to Dr. Kaushik. So, lifestyle and patient education play a pivotal role. So, what specific behavioral routine changes have you found most effective in improving adherence and mobility amongst the arthritis patients?
So let's take the patient education first rather than the lifestyle modification, because at the end of the day, if you want the patient to adopt a lifestyle modification, you will still have to educate the patient, isn't it? Because you will have to teach them what it is. So I will reverse the points and I will speak first. Your first consult with the patient, which will obviously be the longest, because you're getting to know the patient's illness, the patient's structure, the patient's ethnicity, and all of that, the patient's habits, is obviously the longest. And once you have made a diagnosis, you will need to explain what that diagnosis is, what it means in very simple language, and what is it that the patient can expect from this disease when treated, when not treated. What are the pros and cons? And accordingly, what are the medications that I would like to give, and what is the benefit that the patient can expect in what time frame? Having done that, then the next question is, what are the cons of the medication? So once you have put this in place, there are two things that you achieve. One, now you have done what is called expectation management. You've imparted education and knowledge and expectation management. Obviously, the questions that come in are, what are going to be my limitations? What is it that I cannot do? What is it that I can do? And that's where your encouragement comes in. And that's where you will guide them onto lifestyle modification. So that's why I said, let me talk about education first. Because there are certain things, for example, whilst this is World Arthritis Day related conversations and so on, but let's talk about the fact that the patient has multiple kinds of arthritis, right? And so there are certain arthritis which also require, for example, gout, which is a uric acid related arthritis. You require a diet modification. There are certain foods that you can't eat. You will have to skip your alcohol. You will have to stop your red meat, etc., etc., etc. Likewise, if you have, for example, another kind of arthritis, which is part of the autoimmune spectrum, which is called lupus, now the patient can't go out in the sunlight. Now, those modifications will have to be brought in, but after factoring in, which only you can do as a clinician, after factoring in what the patient's work structure and life structure and family structure responsibilities are, because you will have to give them practical solutions. You can turn around and talk a lot, and at the end of it, if none of it is applicable to the patient, then there's no point. In a city like Mumbai, where I hail from, most working women will reach home after 9 in the night. Then they start cooking. And thereafter, they eat their dinner after 11:30, 12. Now tell me, what kind of arthritis patient is going to sustain this kind of a lifestyle? But can I turn around and say eat at 7 in the evening when they're still in office? That's not practical. So I would have to split the meal in such a way that they have a fruit in the night, but they have some snack in the evening. Something like that. This is just a small example off the cuff. But these kind of modifications, now, a patient, if I tell him go to the gym or go to the physiotherapist 3 times a week, he's not going to be able to do it. But if he's living on the fourth floor, can he not use the elevator till the second floor and climb up the other 2 stories? Can he not get off the bus one stop earlier and walk 1 kilometer? Now, those practical lifestyle modifications are individualized depending on the patient's needs, and the patient's disease. That's how you would have to incorporate it.
Very apt examples given, sir. And I think in this, like you mentioned earlier, it depends. And the most important role is the educating our patient. What type of arthritis do they have, and how it can fit the lifestyle changes can fit into their life on basis of the responsibility they are handling. I think that is the right examples given by you. Moving on to my next question, Dr. Indrajit. So, how can clinical research collaborations and hospital-led registries help strengthen evidence-based practices and align India with global rheumatology standards?
Thank you. Once again, it is a very pertinent question. Again, I would like to take the history, because, once you become fairly senior, you've got a lot of his stories to tell. See, these stories came, why this registry in the first place. The first and foremost problem was, again, management and planning. Like, how many patients will be there in a particular area, and what will be the workload next year and so on. And because somebody has to pay. And then some manpower has to be involved that who will be looking after that. And then the third, of course, the most important aspect was research and collaboration. Because we know that in one ethnic area or geographical area, some patient may be very homogeneous, and in some ethnic will be very variable. Like most of the inner city area across the world, like it was like very, very different ethnicity patients will be there. So it was very important to find it out that if you say intervene with one medicine, what is the outcome, and then if you intervene with say medicine A and B, what will be the outcome, and if you see that is there any variation between a different ethnicity and the one who's got say Asian. So all these things were in the background, and which is why the registries became very important. And then you have a lot of data. So if you have a data of thousands and thousands of patients in your registry, then you can work it out. Many, many things you can extrapolate, right? So I think probably India is a vast country. We can accommodate maybe almost one-fourth of the world population now, maybe near about that. So, but then we are not that organized. So what we need to do, at least start the game. It is already started by the Indian Rheumatology Association. Some of the association within the state, they have their own registries. And I personally feel that they are working hard towards it. But to say the least, it is patchy. It is not that robust, all these data are. Now, if we collaborate, then again, all these advantages that we have just sort of, enumerated in the Western world, we can again have Indian data. I mean, I have the privilege to work abroad for so many years, about more than 20 years, and now I'm working in India for about 10 years. So I can tell you that there is definitely a difference between the way some of the diseases present in India and they used to present abroad. So then, the response again, the different patient will have a very different set of problems, that we have in one set of patient versus the other. So it is very important that we do have a collaborative nature of work, whether it is in the state level, whether through the organization like IRA, or through the state, or maybe even corporate hospital. Say, for example, Kaushik, he is in Fortis group. And Fortis again is a very large group of hospital. There are so many centers across India. So we can have a protocol and then we can collaborate. And Kaushik is the right person. He's got so many years of experience with him. Such a, the way he is so practical about it. Almost everybody who's in the panel, they've got worth of experience, a lot of experience with them. So if we collaborate, we can make plan for the future We know exactly that which group of the patients are improving in what kind of medication. Is there any change in intervention that we can do in a given geographical area? And that will be something which I'll be honestly very happy to see it is evolving. Thank you.
Very rightly said, sir, and very rightly stressed upon the collaborative efforts on how the government on global level, or let's say in corporate hospital level, we can work together and have a better standards for this working. Moving on to our next topic, that is collaboration, awareness, and future vision. So my question is, Dr. Sajal. So what role do you think that interspecialty collaboration, like also mentioned about by Dr. Indrajit, between rheumatology, orthopedics, and rehabilitation, can play in building an integrated arthritis care model in India?
Yes, again, thank you so much for that question. This, I would say, is one of the biggest lacunae I see in arthritis care. Most places, most hospitals will have an orthopedician, they will have a physiotherapist, and now many of the hospitals also have a rheumatologist. But rarely, in only some places, do all three of them sit together and run an arthritis clinic together at the same time. Usually, the patient has to go to one person first, then take an appointment with the next person again and see the other specialist, and also then take a appointment with the physiotherapist and get his physiotherapy done. Arthritis involves care with all three of them. Just for example, just to give an example, if a patient is diagnosed with having with rheumatoid arthritis, that doesn't exclude them from later developing other non-rheumatological or non-autoimmune problems causing pain in a joint. They might have a pain due to some, like I said earlier, due to a tendon injury or a tendon tear, which orthopedician can identify better than a rheumatologist. Role of an orthopedician is not just only when a joint surgery is required. There are many other procedures like a tendon release or repair surgery, which orthopedician can help to can do to improve the functioning of the joints. And like Dr. Kaushik beautifully explained, that uh, muscles are the important thing which support a joint. So even if you control the arthritis, joint inflammation, to rebuild the muscle, a role of a physiotherapist and exercise is indispensable. So all three should run an clinic together. Sometimes because everybody has their own expertise. For example, sometimes there is some confusion, and the arthritis medicines, the basics ones are stopped for months before and after surgery, which is not really required. So a combined decision can be taken if all three people are involved.
Thank you so much, sir, for that response. My next question is Dr. Ashish Baweja. So, what are some of the most common misconceptions or myths about arthritis that persist amongst patients and even the general practitioners, and how can we address them?
So thank you for the question again. So I think everyone, every rheumatologist in their practice every day will encounter not just one but multiple questions which are prevalent myths in our society, and we usually try to cater to them as part of our consultation because that is something which is very important. That the communication has to be established. The patient should know about the disease and what actually we are doing. So for the first thing that I would want to point out is that not all arthritis are untreatable. That is a common misconception when it comes to that. That there are arthritis, which especially the inflammatory arthritis, which we are dealing with, that the rheumatoid arthritis or the spondyloarthritis. So if we are able to identify them early in the disease, we don't expect now patients in this age of biologics with small molecules and other therapies with us to form any deformities or have disabling illness. That is something that has to be in there. The second thing is related to treatment only, that we as rheumatologists are not there to simply prescribe patients with steroids or with painkillers. The treatment in rheumatology has moved far way beyond that. And we what we do give is we give therapies which modulate the immune system and help you get back to your life. So what usually we tell our patients is that the drug might not stop, but we'll be able to give back your normal life to you, that your quality of life would improve. And just like any other chronic illness like hypertension or diabetes, you'll be able to carry out your day-to-day activity, just that you'll have to take this pill or one every other day, or let's say once a week. Third, most common misconception that we encounter is with obviously with food, and the disease that we all come to know is uric acid, which is actually per se not a disease. So every high uric acid level will not translate into arthritis or gout, what the name of the disease is actually. So simply having a high uric acid level in your blood does not pertain that you have uric acid associated arthritis, or that is gouty arthritis. You have to have those joint pains which are characteristic to that ailment. They are supposed to be very acute. They are supposed to be like the textbook usually describes them as scrap bitten pain. They're extremely painful. The patient will feel as if they've got a broken bone, but the x-rays are usually normal, and they tend to resolve also. So that is how the pain for uric acid usually develops, and not like vague pains or which can should be treated for uric acid. Then is what has to be taken for that, or what should not be taken for that. As Dr. Kaushik sir rightly pointed out, that red meat, seafood are some things which are actually there in the diet, which increase uric acid or our chances of developing gouty arthritis. The other thing which I would like to point out is fructose containing drinks. So all the sweetened carbonated drinks, they also will predispose a patient who has a uric acid associated joint disease to increase or has flares. And then there is another myth related to milk. A lot of people will ask us, how does milk actually correlate? Because in North India, milk is part of our daily, in North South India as well, in whole of our country, milk is a part of our usual daily diet. So milk actually low fat dairy products are shown to reduce our uricosuric in nature, that is they reduce the uric acid levels in the blood. So we do not see that that should increase anyone's risk. Other things are vitamin C, cherries, these are also associated with reducing the uric acid levels in the blood. And then the common advice regarding food that we usually give to our patients is to simply eat healthy, to manage their carbs, keep on a low fat diet. This is the actual guidance regarding food that we usually want to give to our patients. Thank you.
Thank you, sir. So, as you just discussed about few of the misconception and myths, any bizarre myths you have heard or you would just like to explain us from your patient?
So bizarre myths are actually temporally associated increase in joint pains with the consumption of this only. This milk consumption in North India. So दूध मट्ठा के साथ बहुत everyone complains कि ये लेने से हमारा joint disease बढ़ जाता है. So we actually do not see that happening, and has been going. This is something which every day the patient, so not the patient is going to come and ask us. So that is something you should take milk. Milk is good, healthy.
Thank you for highlighting that, sir. My next question is Dr. Kaushik. So, given your extensive experience, what would be your advice to clinicians and policymakers to the arthritis management more patient-centric and preventive?
Brilliant. So I'm going to take a little out of all the three friends who've been speaking here with me. And, there's a little bit of overlap here and there. So Dr. Indrajit spoke, and then Sajal spoke about the rheumatology, the orthopedics collaboration, and the physiotherapy collaboration. So, one, please understand one thing, that patients with rheumatic diseases, particularly since it's arthritis, we're talking about arthritis, most of them, they will come accompanied by at least one relative, okay, who will take an off or who will skip his work and come with you. So you have missed your day of work, the relative misses a day of work, and then they have come to see you. Most of the times they are not able to travel alone unless their arthritis is totally well controlled, which is a few months down the road. Now, they would have a complication. You need to solve it. Now, imagine you tell them that they need a sonography because you found some little blood specks in their urine report that they did. you found that the liver function is a little off, and so you want a sonography of the liver. So you send right off a sonography, and then you tell them that come back the next day and show it to me. Now you imagine the repercussions. Can you not coordinate it amongst the other specialties as well? Can you not have two slots downstairs in the radiology department, one slot in the CT scan department, saying, would you accommodate my patient on an urgent basis? I promise not to take advantage of the privilege. Now, what happens is you have managed to send the patient down, bring the patient up. He's lost only 1 day. Relative is lost 1 day. But more important than that, you have started treatment on the very same day that you identified that there is a problem. This would require coordination, isn't it, amongst clinicians? Now, most times, what we've done in our hospital is that we've also kind of made investigation packages for our patients so that they are more affordable. And so this is a special privilege that is being conferred for the chronic disease patients by the Fortis Mumbai management. So what happens is here, now we rattle off the investigations. The laboratory has been primed to give me reports in 1 hour. So now the patient comes in, does a fresh sample. By the time I finished examining the patient and explained, the reports are on the table. If I need an extra test because I found something abnormal, the blood is already in the lab. If I need a sonography, the sonography is done. Everything happens in one click. Does that not make it easier for the patient? Now, does that not make the patient more comfortable? Now, this is just an example which we could kind of replicate across other specialties. So we rheumatologists often need the help of a chest physician. We often need the help of a nephrologist, depending on what disease we are dealing with and what are the complications. So coordinating that. But it's also possible that you're working in a hospital where a particular specialist that you want is not available. What stops you from approaching another hospital at an absolutely official level and saying that, let's liaise. If my patient has a problem, would you be able to accommodate and help the patient? Just in case you are short of that specialist or your specialist is on leave. This is my vision of making it patient-centric. Make it easy, make it fast, make it comfortable, and make it effective. So this is what I look at. But the biggest challenge that every rheumatologist in the country will tell you is in terms of the policies. So while our hospitals might be extremely understanding and accommodating for our patients and will be able to help, provided you have been able to explain to them the needs of the patients, they're always willing. The challenge that happens is, tell me one chronic disease that gets covered by any insurance company. That automatically becomes a disclaimer. You don't get a policy. Now, even if you have a higher premium for often declared diseases, pre-existing diseases, so to speak, and if the patient is willing to pay a higher premium, they still are not given an insurance. And this is something that our association, all of us at our individual levels, we've been trying to pull our clouds, use contacts with whoever we know, wherever, at whatever position, to try and get some solutions, some ease for these patients with chronic diseases, because otherwise it's a nightmare. You're talking about a lifelong of chronic autoimmune diseases, paying from their pockets, and they will go well into their retirement and they will be all depleted. So this is the challenge, and this is what I think we should be working on.
So very well explained and very well stressed upon how collaborative efforts can help us we find out of this, and it is very much needed right now, so that we don't want our patient to end up in a very bad condition in their old age or any other condition. Thank you for that explanation, sir. My question is Dr. Indrajit. Sir, how do you envision the next decades of arthritis care evolving with AI, teleconsultations, and digital health integration, transforming patient monitoring and outcomes? Because what I've learned so far is monitoring is something which helps a lot to track any of the diseases out there.
With your permission, Simran, can I just say one myth, which I feel it is very important that we should discuss is the arthritis doesn't happen in children. That is not true. And young children can also have arthritis, which is very important again to diagnose early and treat. And what Kaushik said is absolutely right. This is what the concept is all about: one-stop clinic. One-stop clinic, that means, you ensure that all the resources are available in that particular clinic so that there is an extra space available for joint ultrasonography, CT, MRI, nursing, whatever the other specialties. So I think probably it is very important that, if the patient can be seen the same day, and then the treatment also begins the same day if you have adequate resources through collaborative approaches. Now, the most important question that you have asked, and I'll try to answer, though I feel that it is an ever changing landscape. There are many new AI related modules which will be coming. So it will be very difficult, to what will be in 2030 and what will be in 2035 and what will be in 2050, and what will be the landscape of India in terms of our digital maintenance of the data, and thirdly, that where we will be in terms of our standard of care, as well as, like, in terms of our GDP, because everything is all going to be based on like how much one can afford, or how one state can afford, what will be the resources available. So if I just sort of dissect the question into three different areas. AI. AI is going to have a lot of impact, and I must say that it will be useful for the patient, for the doctors, as well as for the community, because there are certain things which you will be able to say for diagnosis, you will be able to use it. I know I use it, not so often, but in some patients where I feel that, if I want to have another set of differential diagnosis. So, I use it, and then I see that maybe there are one or two things which I didn't think at the spur of the moment. The AI is prompting me, right? Secondly, the AI based kind of algorithms, say, for example, we did talk about the blood monitoring. The blood monitoring can be easily done through the AI related modules, right? So if they can be flagged easily that, somebody's liver function test is deteriorated or kidney function has deteriorated or something or the other, and then the AI picks up and then it sort of, sends a signal to the nurse or the doctor or whosoever is caring. The third aspect will be like, the drug and the drug related complication. So I think probably the involvement of AI in healthcare will be tremendous, and it will be like probably a different scale, altogether in maybe 5 years' time, 10 years' time, 20 and 30. But what we will not be able to replace with the AI is the empathy, from trying to engage with the real doctor and the real patient, and to try to ensure that, look, sometime if I tell to the patient that you will be fine, and they feel so happy about it, and this is what they want to hear. So this is related to the AI. Regarding the digital landscaping, I think probably until unless there is a system through the insurance companies, just like you have in US, or National Health Service in the UK, wherein all the hospitals, they are able to communicate with each other. So there is a digital file, and the digital database, it is enormous. We are talking about billions and billions of dollars or pounds that has to be invested in data center. So, say for example, one MRI will take up so much of data. And then if you have to take the patient, which is like, we are in billion, like, millions and millions of patients, you have to take data. They are approaching different clinics. So it is not an easy work to do, but then still, I think probably with the advent of, data centers all across India, and if you are able to produce the right kind of devices and software, so we will be able to achieve, and that will be very good, because then there will be important that if what drugs the patient has taken before, what kind of problem that the patient faced with, say, one particular intervention, what will be the other past medical history if the patient has forgotten to mention, what is the blood result, for example, in 2020, and what is the blood report now. So I think probably everything will be able to get it in one drop of the moment, which is very useful in the developed world. I have practiced, as I said before, for many years and abroad. So it will be very easy to get all the data in one hand. And then you know that what are the mistakes may have been done and what are the things you got to do or what is something which has been already done. So the third thing, I think probably I am forgotten now. I remember the data, digital landscape, AI, and what was the third one? Sorry.
Monitoring.
Oh, yeah, monitoring. Once again, I think I have covered. So, in conclusion, these are something which is very important, and we are in the infancy stages in our country. But I feel that these three will be taken up by the youngsters and by the government planners, and which will be then very useful for uh, creating. See, like, what I feel if I see that I used to be the clinical director of the whole area. So, which is why my work was also as a manager of the health resources that was there in that particular hospital. So I need to plan that how many new consultants I will require, how much of budget increase that will be required for the say for purchasing drugs, how many nurses I will require and how many nurses we can expect, how many more beds or less number of beds that will be required. So it used to be a very unique advantage that I had an insight before I started doing that role. But what I see here is a very different approach towards it. But that is the professional approach. That once you have the data surrounding your catchment area, the number of patients that you have, then as a government you can plan. Of course, we don't have data, so which is why the plannings can be haphazard. One year we may be talking about arthritis, the next year we may be talking about something else. So it has to be a consistent effort all across the board. Arthritis is important so long as the say osteoporosis is also important and as the renal dysfunction or the liver dysfunction. Okay, so with that I conclude.
Thank you so much, sir. I truly agree that the consistent efforts are required so that we can have that impact what we are aiming for. And this brings us to end of our discussion and what we aimed for to discuss about the arthritis in India, the gaps, opportunities, and the path forward. I think we got some really insights from our experts out there. You just gave us your valuable time and expertise on this important topic and came across, on this platform to discuss this. Thank you so much for your time, for your valuable expertise and insights shared by you. It means a lot to educate and aware our public out there. Thank you so much.
Thank you.
Thank you all. Have a
Thank you.
nice
Thank
evening,
you.
whatever you are up to. Thank you.
Thank